Ladies and gentlemen, thank you for allowing me to present to you the updated International Society of Thrombosis and Hemostasis guidelines on antithrombotic treatment in COVID-19 on behalf of the guideline panel and the ISTH Council. I am Sam Schulman, professor at McMaster University, Hamilton, Canada. These guidelines were in the first version published in 2022, but I will talk to you about the updated guideline from 2024. My disclosures: a research grant from Octapharma, honoraria from a variety of study committees, mainly on direct oral anticoagulants. I'm employee of the McMaster University, and the other panel members have their conflicts of interest available in the guideline publication. The reason for such a quick update from 2022 to 2024 was that this field was moving fast forward. Virus variants were changing quickly, and then the whole clinical picture was mitigated by vaccination. But there was also a question about the safety of the vaccines and what to do with the rare complication of vaccines. In this process, we had a panel of 16 clinicians, content experts, 2 patient representatives, and 1 experienced methodologist. We were divided in 4 working groups addressing hospitalized non-critical ill patients, hospitalized critically ill, patients who were non-hospitalized or were after discharge, and a new section on vaccine-induced immune thrombotic thrombocytopenia or vaccine-associated thrombosis, so VIT. The methodologist, Elaine Resnick, freelancing but with a lot of experience from guidelines, helped us with literature search. She had initially helped us with all the old questions that were in the first guideline and came back now. And now she focused on the PICO questions on VIT and vaccine-associated thrombosis. She has associated reviewers that help to screen the abstracts. So the working groups then received the selection of abstracts, and we also performed renewed literature review between 2022 2024 for all the other questions. New studies were added, and then the working groups had internal discussions, reaching draft recommendations, and also suggesting if any old recommendation could be sunset. We are using the American College of Cardiology Foundation, American Heart Association methodology, which is very suitable when you need a fast process. And although our organization has previously used the grade methodology, we found that that would take too long time. The ACCF-AHA methodology is used by several organizations, and it's quite illustrative. There are, as you can see on the right side, the decision on the quality of evidence, so LOE, level of evidence, and in the initial guideline we had already decided that we would only include studies with level A or B, so that's randomized studies or non-randomized at a very high quality. I'll come to you soon about that we had to deviate from that regarding VIT. Then the working group has to look at the class of recommendation. There are essentially 3 classes of strong, moderate, and weak, and then there is also that strong against. Within each recommendation, there are prescribed wordings from stronger to weaker, so one has to use one of these wordings that is most suitable. So between these 2 years, there was new evidence from 14 new randomized trials, 2 secondary analyses and 2 meta-analyses, and they were all used as basis for the updated and new recommendations. However, for VIT and vaccine, we had new PICOs. We wanted to address the risk of thrombosis with vaccines, especially in patients with thrombophilia, the diagnosis, type of anticoagulant that can be used, and regarding the use of intravenous gamma globulin. Our previous rules did not apply anymore because we, for all the other questions, used the rules that the randomized clinical trials had to have at least 100 patients and the observational studies a minimum of 400 patients. But that does not apply to rare, very, very extremely rare complication to vaccines. So here we have the timeline. In April 2023, ISTH approved and budgeted the project, and we had the first Zoom meeting. In May, we had literature searches, and then between June and September, we had recurrent Zoom meetings where the different working groups presented their suggested recommendations, and we had discussions, criticisms about that. In October, there was finalization of the text, and we voted virtually on it in November. And the following month, the manuscript was submitted to Journal of Thrombosis and Hemostasis. So this was a process of less than a year. Let's go to the first group chronologically, which is the patients that are infected, but they are not in hospital. And the main objective is, of course, to prevent them from disease progression so that they don't need hospitalization. For direct oral anticoagulants, there was one previous RCT, and then there were 3 new randomized trials. All of them failed to show any difference in outcome of disease progression, but also regarding other outcomes. So there was a clear level A recommendation regarding quality that there was no benefit. For low molecular weight heparin, we had now new study, 2 randomized trials, both on enoxaparin, and they showed no difference in the primary outcome, hospitalization or death. So this was a new recommendation in the updated guideline that with level of evidence B randomized studies, so it's 2 not very large studies, but the class of recommendation was that there was no benefit. We move over now to the patients who are hospitalized, and they, please note, are hospitalized because of COVID infection. So this does not apply to patients who are hospitalized for other reasons and happen to be infected during their hospitalization or diagnosed with COVID during the hospitalization. And they are on the regular ward. Most of the studies included patients that have increased risk of progression for one or another reason. They had high D-dimers or other risks. So the first question was, is therapeutic dose low molecular weight heparin or heparin better than prophylactic dose heparins? And there were 3 new RCTs together with several previous RCTs and a meta-analysis. And whereas 2 small RCTs showed no difference, but probably they were not adequately sized, but then a large one by Stone with over 2,000 patients showed absolute risk reduction in death by 2.1%, statistically significant. And in the meta-analysis, there was also absolute risk reduction in death and also in major thrombotic events without a significant increase in major bleeding. So the conclusion is that with level of evidence A, many larger RCTs showing the same thing, that reduced death was a benefit. And although we had a recommendation on this before, but we didn't include death, but that was now included because we had the evidence. Whereas with intermediate dose heparins, there was no difference in outcomes, and that together with the previous RCT confirmed. Now with 3 RCTs, level of evidence could be upgraded to level A, no benefit. Regarding DOACs, there was a large study, and that's again the STONE study. With this part was with apixaban at a therapeutic dose compared with prophylactic dose low molecular weight heparin. So again, there was an absolute risk reduction of 2%, and there was reduction also in end organ failure and no increase in bleeding. Whereas with a very low dose of a DOAC, namely in the COMPASS regimen, the rivaroxaban at a dose of 2.5 milligram twice daily plus aspirin, there was no difference in outcomes. So the conclusion was that therapeutic dose apixaban, which was with almost identical results to low molecular weight heparin at therapeutic dose in the STONE study, but it's only one study with apixaban, and the p-value is 0.04, so it's a careful recommendation that we say it's not well established but may be considered. So level of evidence is B, randomized, and class of recommendation 2B. Moreover, we now move to the critically ill patients. So they are either in an intensive care unit or in an intensive care unit-like setting, because ICUs were often overwhelmed during COVID pandemic, and patients had to be treated with similar level of care in other parts of the hospital, but were included in the studies. So intermediate versus prophylactic dose heparins, there was in one study a reduction in thromboembolism, in another one there was no difference, and we had 2 previous negative studies. So overall 3 studies that didn't show much of a benefit, and all of them failed to show any benefit regarding mortality. So the level of evidence was upgraded to level A for the outcome of death. But we did not address in the recommendation thromboembolism since there was some inconsistency in the results. Now, for therapeutic dose, which was the one we strongly recommended in non-critically ill patients in the hospital, here in the critically ill versus prophylactic dose, there was in one study no difference in outcome, in another borderline, and in the third one reduction of thromboembolism, but not in death. So there were inconsistent results, but there were consistency in all these studies that there was increased major bleeding. So overall there was more harm than benefit, and because of that, level of evidence could be upgraded to level A for no benefit. For, again, critically ill patients, but now looking at antiplatelet agents, 2 new randomized trials by Berger and Bohula, and they showed no difference in any outcome. We had in the first version of the guideline 2 RCTs, of which 1 was negative and 1 was positive. So we have now 3 negative, and all of them show that there could be increased bleeding. So level of evidence was upgraded to level A, that there's no benefit. Patients who have been discharged from the hospital, in one DOAC study with, and this was a new one, by Wang, 1,200 patients. There was no difference in outcome by giving DOAC versus placebo, but this was not a high-risk population overall. Whereas observational studies and an older RCT that was already in the first guideline showed downward trend in venous thromboembolism, arterial also, and death. So the new recommendation is that overall no benefit from direct oral anticoagulants, level of evidence A, but, and this is now a changed recommendations from previously weak, but we added that yes, one can consider the low dose, the prophylactic dose, rivaroxaban 10 milligram daily for high-risk patients. So that is for selected patients. Moving on to vaccination. So first of all, should we give any prophylaxis to prevent thrombotic complications associated with VIT in patients who receive vaccination for COVID? And Houghton looked at, in an observational study, a very large number of patients that he compared the incidence of VIT 3 months before versus 3 months after the vaccine, and then looked specifically among those. There were 6,000 patients with thrombophilia and who had had previous thrombosis, and there was for after VIT after versus before an absolute hazard ratio of 0.81. So it was no signal of increased risk, even in patients at elevated risk of thrombosis because they had thrombophilia. So in conclusion, we say that since it was not increased risk for this higher risk patient, then it's definitely not for the general population. So level of evidence B, non-randomized, and that there is no benefit of prophylaxis against thrombosis when you give the vaccination. For laboratory diagnosis, there are different tests, and mainly the anti-platelet factor 4 enzyme immunoassay and a rapid hit assay. 6 cohort studies looked at the enzyme immunoassay, and overall they had negative predictive value of 1.0 with a range of 0.76 to 1.0, and good positive predictive value also. Whereas the rapid hit assay was only one eligible study that used an appropriate gold standard for comparison, and you can see that the predictive values were poor sensitivity specificity also. So the conclusion was that a negative anti-PF4 enzyme immunoassay essentially rules out VIT, and that is what we recommend. But a positive, if it's not 100%, but if it is together with substantial clinical suspicion, it essentially rules in VIT. Whereas rapid hit assays are not useful, and a false negative test can delay treatments that can be life-saving treatments, so we should not use them. And then finally, for treatment of VIT, so since VIT is similar to HIT, or heparin-induced thrombocytopenia, there was hesitance against using heparin for these patients, and it was recommended to use like argatroban, bivalirudin, or similar. But there are 3 cohort studies that and a meta-analysis that showed no difference in mortality or dependence between those that got heparin versus non-heparin anticoagulants. So this is important, especially for care settings where there is no availability or they can't afford, in certain countries, argatroban, bivalirudin. And For intravenous gamma globulin, 3 cohort studies, 2 show significant reduction in mortality, 1 could not show that. So in conclusion, I mean, these studies were a small number of total patients and in these treatment studies. They were non-randomized. They were confounded by the use of other concomitant treatments, and there was a change in mortality over time that resulted in substantial confounding. So the recommendations are mainly weak here, except for heparins that we say that they seem to be okay, 2A. But if you have availability of the non-heparin anticoagulants, you should probably prefer to use them. And with that, I will want to thank all the panel members and other that supported this guideline. Thank you.